Soft tissue injuries. What does this mean? Soft tissue, so pertaining to the skin, muscles, adipose tissue, all that fun stuff. All right. There's different kinds, different etiologies, if you will, and subsequently different management of these different types of soft tissue injuries. Alyssa.
Yeah.
What's up?
I told you that 30 seconds.
Yeah. Anything. All right, so guys, most of the time, soft tissue injuries are going to be life-threatening or not life-threatening. Most of the time, not life-threatening. Where do we run into problems? Okay, so maybe when that soft tissue is also, we go deep enough where it compromises like a vessel, like an artery, or if there is any type of significant internal bleeding with that, but usually these are non-life-threatening injuries. When we do go to that life-threatening, again, it's secondary to that, the bleeding, the blood loss, and infection too. What does that mean? How can that be a factor? Yeah, because guys, what is our skin? It's a barrier. It's a big, like every aspect of our skin, as long as it's intact and closed, it is an organ, it is the largest organ in our body, yes, but it's a protective layer, right? That's a big, big reason that all of the germs and bacteria and all of that stuff stay outside in this environment and they don't make it in my body, in my bloodstream. So if that barrier is compromised through that soft tissue injury, those organisms can find their way in. We can get an infection. Infection can turn into what? Sepsis. Septic shock's not good. That's a common cause of death. Right? Yeah. Okay, we just talked about that. Perfect. So guys, overall important thing to know about trauma. Okay, what's our first and foremost when it comes to these injuries? The first thing we want to try to do is what? If it's a life threat? Stop the bleed. Stop the what? Stop the life threat. Yes, but particularly with the soft tissue injuries, stop bleeding. Okay, we'll talk about how to do that, particularly next chapter, which we're going to do when we come back from lunch. But yeah, we want to stop the bleeding because all bleeding stops eventually, right? Whether we do it or we run out and the patient dies, okay? But then also protect from further damage. That's another big one too, especially with the soft tissue management. We want to make sure that the entire soft tissue injury is covered, so we're protecting it as best as we can from outside germs and sources of infection. So stop the life threat and then prevent further damage are two main principles when it comes to our trauma maintenance of these injuries. Skin varies in thickness, okay? So the skin in the palm of your hand is a lot thicker and more durable than, say, the skin on your eyelids, right? Skin itself is what in nature? Stretchy sometimes. So we do have elastin and collagen that gives it kind of the stretchy aspects, but it's got what supply to it? Blood. And it puts the lotion on. All right, so it's usually vascular. Some areas are more vascular than others. Okay, so what areas are very vascular? Okay, the face and the scalp. Guys, you will bleed like a stuck pig. A small laceration to the scalp can produce copious amounts of blood. Not usually so much that I'm concerned with hemorrhagic or hypovolemic shock.
But at least nothing scary.
But enough where you'll be like, oh my God, what kind of injury? I gotta have like exposed brain matter, and like you clean it up and you get to the source and it's just like, you know, a little lack right here. You're like, oh, all that for that? All right, and it also has what supply? Nerve supply. Okay, but the thickness, the amount of durability varies in different places of the body. So ears, lips, scalp, eyelids, all of this stuff, if it's thinner, it's easier to damage, break, rupture. Okay, so just keep that in mind. What else do we need to keep in mind for that thin skin? Who else has thin skin? Babies, yeah, kinda. Geriatrics, right? Guys, why do we start getting wrinkles the older that we get?
Shrink some.
Huh?
Shrink some.
So we kind of, yeah, our height, surface area sometimes shrinks a little bit, but what else? What do we lose? Elastin and collagen, all of that component that keeps the skin nice and like taut when you're young. It starts to kind of deteriorate and degrade. You start to see those wrinkles because that's not there. Guys, that collagen elastin provides more of like a plumpness to the skin. So with the geriatric patients, when they don't have that elastin and collagen, guys, their skin is paper thin. All right, so you can get significant, like just barely, like with my Grams, she would be walking in the kitchen and just barely bump her arm up against the counter and she would have a skin tear and a bruise from like here to here. Okay, so paper thin skin, more susceptible to soft tissue damage, more dramatic response, like with the bruising and stuff, the older the patients get. So keep that in mind.
Have you ever seen someone really stretchy skin?
No, not in real life.
When you were contesting.
You know what? Oh, okay. You got all sorts of oddities, don't you, bud?
Glad I wasn't watching that, I don't know what happened.
So guys, the main structure of the skin, just going back over review of anatomy, we've got the epidermis, right? What is the epidermis? Where your epidermis is showing, right? That's going to be the external, everything that we can see visibly is going to be your epidermis. We go down into the deeper layer with the dermis, and then we go down to that subcutaneous tissue where we start to see this. What is this? Fat, adipose tissue, that kind of yellowy, like jello looking stuff is going to be fat. If we see that, what can we infer? Okay, so yeah, we'll get back to that. Did we talk about this? I think that's orthopedic. Maybe we'll come back to that. Again, guys, our skin also contains like mucous membranes. It has pores. We use the pores to do what? Thermoregulate, right? We sweat through the pores, helps cools us down. What can pores also do?
Absorb some ways.
Absorb. Okay, so yeah, through the sweat, but we can also absorb stuff through the pores, through the mucosal membranes as well. Keep fluids in, so plasma, water fluids, blood. Our skin needs to be intact to make sure those things stay in. All of the bacteria that we were talking about stays intact. It keeps that out. Thermoregulation. Okay, so we just talked about sweat. It helps cools us off. All right, what else do we do to help keep us warm? Okay, so we kind of pull the blood towards the core, right? But what else happens? We get goosebumps. Right, if we're cold, we shiver, right? That musculoskeletal aspect, that movement helps heat is a byproduct of movement. So the constant tension of the muscles creates heat. But yeah, we get the goosebumps, right? That erector pillae muscle right here that's connected to the hair. It pulls taut, it becomes erect, the hair stand up, it traps the body heat, it serves as kind of like an insulation. Okay, so thermoregulation, yeah, does a lot of stuff. All right, so 3 types of soft tissue injuries. A closed injury, what do you think this is? Okay, so it's going to be more so like a blunt trauma, right? The skin is not perforated, the skin is not broken, the skin is still intact. Give me an example of a closed injury when it comes to soft tissue. A bruise, a contusion. Guys, what's a bruise? What happens? We just talked about it.
Capillaries rupture.
Capillary beds to that particular area get burst or get busted. They burst. The blood pools right there towards the top of the skin. We start to see that discoloration. Typically with the black and blue, the darker colors at first. We'll talk about that a little bit later. But yeah, that's going to be a closed soft tissue injury. An open soft tissue injury. The skin is perforated. It's penetrating trauma, right? The skin is no longer intact. So we no longer have that barrier to keep the good stuff in, to keep the bad stuff out, to help more so thermoregulate. Okay, so a laceration is going to be an open soft tissue injury. And then we have burns. They're their whole specific type of category. Okay, we're going to jump into burns at the end, towards the end of this chapter, but they're kind of a whole nother ball game of their own. Okay. So guys, what happens when we get a soft tissue injury if we're healthy and don't have like hemophilia or anything?
We would collect.
Okay, so we heal ourselves from the inside out, right? We have an increased amount of blood flow rush to that particular injury site. So for here, we're talking about soft tissue injuries, all right? Who starts to kick in first? In the blood. Platelets, right? That clotting cascade gets triggered. So our platelets rush, they clot together, the bleeding stops, and then eventually we start forming a scab. All right, so our skin cells regenerate. We get new skin, we close it up so we don't bleed out and there's just not an open gaping sore. But we heal ourselves from the inside out. We have new blood vessels that form, all the collagen usually ideally is replaced. It's really cool how skin can like regenerate like that, but we heal ourselves from the inside out. Okay, so typically guys, these closed soft tissue injuries again are going to be secondary from blunt trauma. All right, history of blunt trauma. If you just got hit in the arm with a baseball bat and your skin is intact and you have a contusion, it's because you have a history of recent blunt trauma, right? Pain at the injury site, all right? Swelling, discoloration, those are going to be the biggest factors that we're like, ooh, we've got something going on that's either maybe internal or just a closed soft tissue injury. All right, so we've already defined a contusion, guys. That's the fancy pants word for a bruise, right? The capillaries to that particular area break underneath the skin. The skin itself does not usually get perforated. All right, guys, what is important to understand when it comes to documenting trauma injuries? So particularly, we talked about the penetrating trauma for like maybe a GSW. Okay, we can't say entry versus exit. We say where it is and describe it, right? How do we document bruises on our patient? Okay, so give me an approximate size, approximately, 6 millimeters wide and like a 6 millimeter by 2 millimeter, kind of just a surface area. We need to be particularly careful about like the shape. Like, what were you thinking?
There's 5 lines, or 4 lines.
Okay, so you could say there's like 4 lines that are like what, parallel to each other, something like that. That's objective. Yes. We probably don't want to go to the extent of saying notice an approximate X size contusion in the shape of a hairbrush or something like that, because can we 100% objectively say what caused that bruise? Okay, we can,
Unless somebody tells you.
I mean,
unless that,
if you're a reporter, you're supposed to report like
yes.
landmarks on the neck.
Yes. So guys, if you see like a full-blown handprint or like where the fingers would have been, like you're talking about the 4 lines, your spidey senses should start kicking in, right, about possible abuse. So yes, we're a mandated reporter with that, but we have to be careful because our documentation is strictly based on what? Objective physical findings. So tell me where in location the injury was found, give me an approximate size, and then also tell me what?
Color.
Tell me the color. Why does the color matter? All right. You can't say, notice a new bruise or a fresh bruise or old bruising. Okay, because can we 110% prove that through objective findings? No. But tell me the color, the location, the size, and the color of bruising. Guys, what does a new bruise look like? It's
usually
darker
kind of
color.
Yeah, it's kind of usually purplish dark.
That's where we're going to have the really deep purple colors, that black color, the dark blue in color. All right, that is a very fresh bruise. Okay, that is new, fresh blood from those capillary beds that have accumulated in that spot very recently.
I remember about 3 months ago, I fell down those flight of stairs, but on my butt, and I still have it. I have a huge hematoma on my, and I have pictures of the whole bruise, like from when it started to when it was
Like tracking it?
Mhm.
Yeah,
Yeah, it was pretty big.
pretty massive.
Yeah, I'll show you later.
Okay. Do you want to share those with the class?
I mean, it's my butt cheek, so I don't know.
I'll look at them later. But yeah, guys, the older the bruise is, the color starts to change. Because what's happening to make that color change? It's healing, but yeah, so like the blood is being reabsorbed back into the body. If there's any type of like the white blood cells involved, like them, eating away at that bad tissue, that starts to change the color. So when we start to see like the green color and the yellow color and like the brownish color, that's an older bruise. That's in the later stages of healing. Guys, why is this so important that you document all of those aspects of these injuries that you find?
Like whether
Okay.
or if it was like an abuse case like that. Okay, it's just
Guys, abuse cases. It's not something you want to think about. It's not a fun thing to deal with. Trust me, I was like a magnet for them. But you have to build an objective case. I couldn't say that, suspected repeating abuse to this 6-year-old child. I could give my objective findings to say there were several locations of several different color bruises, and I will give that off because that's my patient care report, that's my objective findings. I'll pass that off to the lawyer to let everybody else interpret. Oh, well, if you said that she just fell, but she's got a shit ton of old bruises, that's not a recent injury. Where did all of these injuries come from? Okay, so not a fun thing to think about, but especially in abuse cases, you've got to objectively chart, especially the color, because it could have been just a one-time thing, but usually, guys, if it's an abuse case, it's not just a one-time thing. It's a reoccurring thing that happens often.
Can you just briefly repeat the sequence of colors?
So the darker, like the dark blacks and blues and purple indicates a very recent. And then typically when we start to see like the greens and the browns and the yellows, that's in a later stage of healing. So if you have a significant amount of yellow colored bruises on top of purple colored bruises, these are different injuries. This is not coming from the same one-time incident.
What if you find like objective signs of abuse that are like unrelated to your patient, like maybe like get a call for like mother, but like the signs on like the daughter or something.
Are you a mandated reporter?
So you can still like.
How would you document something like cigarette burn?
So you would tell me location where you found them and a description, an approximate diameter of the burn itself. Tell me the color, tell me the condition of the skin around it. And you could say, noticed, several of these injuries that appeared maybe uniform in presentation. You can't say, noticed several cigarette burns. But you can give an objective finding that the lawyer can say, oh, well, it looks like these came from the same source. But you can't straight up say that in your chart.
So somebody from legal review any case?
Like at grading?
Yeah.
They get involved. They don't like get flagged.
What triggers them?
When it starts to progress through the, hey, this is actually going to court. Then they get involved. So they prep you, they give you your chart. They say, these are the questions they're going to ask type thing. Okay. So yeah, guys, particularly the bruising, please tell me the color, because that's a very strong objective finding that can be used to be a patient advocate in abuse cases. hematoma, what's a hematoma? So yeah, this is gonna be, it's an excessive bruise. A hematoma is where we have all of these capillaries that burst underneath the skin. Typically the skin is not broken for a hematoma, but the amount of blood that's released causes like a localized swelling. So you said you kind of had like that raised area, it kind of like maybe like a goose egg, right? You can have like a knot in your head from the swelling of that particular injury. That's gonna be considered a hematoma, but the skin's not actually broken, but you see like notable localized swelling from the accumulation of the blood underneath the skin.
Like if I stand up, you can still see it in my hands. That's how big it is.
What?
Yeah, I thought I got it checked out.
How long ago did this happen?
Like 3 months ago.
Oh.
You might want to get that checked out. I will.
Okay.
Eventually.
Yeah.
Is it still discolored?
No. It hurts just a little bit. And you can still.
So you might have like maybe
Probably
like
like some blood accumulated in
or maybe like a cyst, like just fluid that was released from the damaged tissue just accumulated and didn't get reabsorbed. So yeah, I might suggest getting that looked at. All right, what's a crushing injury?
Everything goes on top and it stays on top.
Okay, so if something falls on you and crushes that particular body part, why is that bad? What's happening? Okay. Okay, so we already talked about, guys, if we have an injury site, what happens? What does the brain do? We heal ourselves from the inside out. What happens to that injury site? Swelling, because we have that increased blood flow so we can heal ourselves from the inside out, right? So depending on the amount of force, how heavy the object was and how long the object was on the patient. So again, guys, we could get a crush injury in like an MVC, right? If it's like a rollover and the patient's pinned and crushed and we have to wait for them to get extricated type thing. But for typically more than 4 hours, we start to see the bad effects of that swelling with that, the blood from the injury. It doesn't have anywhere to go, right? We can see significant problems with this. We'll talk about that in a little bit later, I think, in this chapter. But yeah, if our patient's pinned, we want to know how heavy the object was, how long they've been pinned. Are we going to be concerned with crushing injury and then eventually compartment syndrome or crush syndrome? Okay, so yeah, here we go. Compartment syndrome results from the swelling that occurs whenever tissues are injured. So guys, if the amount of swelling exceeds the surface area of that body part, we start to run into problems, right? Because if I have something that crushes my leg down here, I only have so much space for all of that swelling to go. Okay, what's going to start happening if I've got all of the swelling putting pressure around that area and I don't give an outlet for that pressure to be released?
It's gonna cause damage.
It could start.
Oh, why? What kind of damage? Okay, so but what is pressure damage?
Just gonna cut off blood flows, squeeze the-
So all of that pressure can actually occlude blood flow to the surrounding tissue. All right.
And it can eventually start damaging your skin too, because it'll start trying to make its way through the skin.
Yep. So yeah, compartment syndrome is not good. Okay, we'll talk about that progression of that a little bit later. All right, so open injuries. We got 4 main categories of open injuries. All right, what is an abrasion?
Right.
Guys, this is the very, very top, that superficial layer gets kind of just like a friction burn, if you will. So like, anybody ever experienced like rope burn or carpet burn or like road rash? That's typically an abrasion, all right? We can see a little bit of bleeding, but usually it's just the top part where we see just kind of that plasma that starts to come out, like that clear yellowish tinted stuff that kind of just oozes. But yeah, that's gonna be an abrasion. I think we treat that.
Irrigate really well. Non-stick. Bleed a lot.
you guys, in every single soft tissue injury, if there's a crap ton of like dirt or debris or anything like that, what do we want to do?
Get that out.
Kind of wash it out. We have those jugs of sterile water we keep on the truck. We're going to use that to just very gently, not with a ton of force, just kind of clean any debris out of the wound. All right, but what are we going to put on top of that? Yeah, just some gauze. We're not really concerned with a lot of blood loss. We're not really too much concerned with like the non-stick pad. We'll get to that later, Andy. But we're just going to put some dry dressing on top of it to secure the dressing. All right, so guys, I put on each of your tables different types of dressings you're going to see. The little squares, all right, are going to be what we call the 4x4s. Those are the infamous 4x4s. We use those for a ton of different things. All right, so depending on the surface area of the, so that's going to be a 4x4, guys. It's just literally 4 inches by 4 inches, and it's made out of a cotton-like material. And it just we can use this for small bleeding control, things like that. So just get a 4x4, put it on top of that abrasion, and secure the 4x4 to the rest of the skin. Guys, what's important to remember about when we put any kind of dressing on a soft tissue injury, when it comes to the size and the shape? Yeah, if I have an abrasion that's this big, make sure the dressing you're putting on that abrasion is this big, right? I want the entire area of that soft tissue injury to be covered with this dressing and then some. I want some wiggle room, right? So if you have to get multiple 4x4s and, you know, place them and make it longer or wider, please do that, because we have to secure the 4x4 to the intact skin, right? What are some ways we can do that? We can use tape. What else can we use?
We can use this.
Okay, so this is great. I love this stuff. This is called Kerlix. So what it is it's the same material as the 4x4, right? It's just that cotton based. It's got a little bit of a stretch to it, but you can do whatever with this, right? I can take this, instead of taping a dressing down, I can put a 4x4 down here, put the Kerlix on top, and then just wrap the Kerlix and use that to secure it. Because what else does this do? Doesn't, I mean, it's not
It's not like does it stick to itself? Like,
not as much.
okay, that's what I was.
Okay, I can apply pressure with this, right? If I want to put what we call a pressure dressing, I can put a little bit of force. I can wrap it kind of securely. But what else does it do? It secures, it can apply pressure, and it absorbs. So if I've got any blood kind of leaking out of that 4x4, this will absorb it and this will stop the blood. This is very versatile, especially if you've got like a head injury, right? Do we want to tape a 4x4 on somebody's hair? No, use this thing to secure. Use the Kerlix to secure. And guys, typically you don't need to use the whole roll. When you get to the point where it's secure, just cut it with your shears and then tuck it underneath a little side, like one of the sides of the area, or just tape it down. So that way too, when we remove that, we're not pulling tape off of skin. Okay, Kerlix is a really good versatile thing we can use. Please don't ever place tape directly on a soft tissue injury. Is that fair enough? We want to make the surface area of the dressing larger than the surface area of the injury to avoid putting tape on top of an abrasion. Okay, guys, be generous when it comes to that. If it's an abrasion this big, you can wrap that whole forearm up, right? I don't want to be compromising any already damaged tissue, causing any more pain, all that jazz. Okay. You also have a trauma dressing on your table. All right, these come pre-packaged. So since you guys aren't looking at me stuff, this is one example of a trauma dressing. This is the abdominal pad. This is one size. This is this one right here. They make, did I give y'all the really big one? All right, so they make different shapes, different sizes, but guys, what is this? It's a 4x4 on steroids, right? It's got a much larger surface area. It does inside have that cotton material that will absorb the blood, but this is for bigger areas, like bigger soft tissue injuries, okay? So if you, they call it abdominal pad because it can conveniently like wrap around the abdomen. But if you've got an abrasion, you know, right here that covers a bigger surface area, instead of using a crap ton of 4x4s, just get this out, wrap that puppy around, and then just tape it down, right? You can cut these to size. If you need something bigger than a 4x4, but you don't need something this big, just take your shears and cut it in half. You can cut it to shape or to size the injury. Just make sure that the surface area of the dressing is larger than the surface area of the injury site itself.
Do you save what remains or do you dispose of that?
No, you're gonna throw it away. I mean, I would save it just in case you need to use it on the
On
patient.
that patient,
But yeah, afterwards it gets tossed. Okay. Guys, you have, I passed around, we've got ACE wraps on the truck as well. So if that would be another thing you could use to create a pressure dressing, which we'll talk about later, or just to simply secure any type of 4x4 or additional trauma dressing. You can use an ACE wrap because it has that Velcro end, so it can Velcro attach to itself. Okay, so dry dressing exceeding the surface area of the injury site itself would be how you would treat an abrasion. All right, a laceration. What's a laceration? A cut. Okay, typically, guys, a laceration is going to be kind of jagged. It's not going to be very precise or very clean. We define that as an incision. So here, I mean, I might define those as an incision. It looks like this got caught in maybe some machinery, right? Because it's the same width apart, looks clean. But typically, like a surgical incision, it's very precise with the scalpel. It's intentional. It's clean. It's not rough around the edges, if you will. Okay. We're going to see more blood loss with this externally, right? Because we're going deeper down into the dermis. Because that dermis is where the most of the vasculature is going to be. So we might see more blood with this because it's going deeper into the skin. How are we going to treat that? Same way. Guys, I'd probably get that really big trauma dressing, take it out of the pad, and just put a dry, sterile dressing, wrap it around the entire leg, and then just tape the trauma dressing to itself. Okay, so just dry, sterile dressing when it comes to treating a laceration. Depending on the amount of blood loss, you might need to do a pressure dressing. So what does that mean? What's going to happen here? Yeah, so it's when something bleeds, what do you typically do? You apply pressure, right? Gives a little bit more, not security, but reinforcement to allow those platelets to stick together and form that clot and stop the bleeding, okay? So if the bleeding is only controlled from your patient's injury while you're applying pressure, and when you relieve the pressure, it's not clotting, it's still bleeding, you can get a crap ton of 4x4s or, you know, the abdominal dressing, the trauma dressing, place it there, and then typically with the ACE wrap, we can apply it more taut. So with the ACE wrap on top of the gauze, it's actively pushing down on that site and causing pressure to be applied, hence pressure dressing. Okay. Everybody hear that? Definitely. Okay. Ooh, an avulsion. What is an avulsion? Okay, so this is kind of where the skin is hanging on by a thread, if you will. Right, we've got skin that has been removed, but it's not completely detached. It's a little skin flap, just hanging on. All right, so here's kind of a visual for just the imagery right here. Here's what it looks like in real life. Down here, that's all skin. Where's that skin supposed to go?
Kind of up there.
Right here. Okay, how do we treat an avulsion? All right, so again, if there's any debris, we want to get that sterile water. We want to rinse off the site, guys. Same with an abrasion or a laceration. Any significant debris, we're going to try to clear it off just a little bit, and then we're going to apply the dressing. So we'll clean this out, flush it out, and then we take that flap of skin and we very, oh so gently, kind of place it where it should be. Like put the flap back to where the skin should be, and then we do what? A dry, sterile dressing and secure the dressing. Okay, so if you got a flap of skin, just kind of like tuck it in right there and be like, hey, you can go back to your home and the surgeon or the doctors can stitch you up when you get to the hospital. All right, guys, do we do stitches in the back of the truck? No, we do what? Stop the bleeding, prevent further harm, and get them to the hospital where they can get surgery or stitches or whatever they need. Okay. Ooh. What is this? Degloving. What happens here? So more often than not, guys, we see this with jewelry, particularly on the fingers. If you know, they're especially working with machinery or any tools or anything like that, if the jewelry itself gets stuck on something and that jewelry becomes stationary, that ring becomes stationary because it's stuck on this object, but the hand continues to move in an opposite direction of that jewelry. All right, typically what will happen is the ring will just kind of take the skin with it and just go. All right, so that's what happened here. Okay, so you can see bone here. It just kind of like degloved the skin to that finger, and most of the time it's from jewelry getting stuck on something, moving in opposite directions. Okay, here's another example of degloving. Maybe a watch got stuck and the watch was moving this way, patient was moving this way, and then the skin just went with the watch because that's the path of least resistance.
The rest of his arm looks really
Looks like he's got something here. I think that's just
looks
hair.
like an old couch.
No, I think it's just hair.
So I gotta hand it to you.
Uh-huh.
I'll be here all week.
Guys, what's this?
Oh, evisceration.
That's how.
Mm-mm. That's a penile degloving.
Oh.
Wow.
That's how you can't tell how it is.
How'd that happen?
I added this picture on here because I've had this call. It wasn't to the extent. All right, so penis, testicles. Jay's like, oh.
Yeah, his legs are going this way.
Yeah, leg. Yeah. Typically it's because of jewelry again. Being recorded, this is really hard. So particular items, rings that are used for any type of sexual activity. Sometimes once they're placed before things become erect and the size difference changes, and sometimes they won't come off, and the dude freaked out. He placed it on himself, and when the size differences didn't allow him to remove said item, he freaked out and tried to kind of like rip it off and had a partial degloving. So
Termination.
yeah,
I give him a lot of credit for hopefully.
yeah, I think it was just like a freak out moment. Mhm. So yeah, genitalia, soft tissue trauma. What do we need to keep in mind?
I just didn't realize the jewelry in that area, so today's a really interesting day.
New doors
Yeah.
opened up for your knowledge.
Thank you.
You have to do an insurrection off Cheshire Bridge, there's all kinds of stuff.
Pardon me?
Insurrection off
Yeah.
Cheshire Bridge,
There's
lots of stuff, you know.
Yeah. Yep. Genitalia trauma.
That's the mother of all distracting injuries.
Okay.
All I care about.
So it can be a distracting injury, all right, particularly in males. All right, this dude, you could have chopped his arm off and he would not have cared. Are they gonna be okay? We're gonna have to cut it off? They're very, genitalia is very vascular. All right, so there's a lot of, it's going to bleed a lot, and it's also very rich in nerve supply, so it's going to hurt a lot. It is a visual, traumatizing, can serve as a distracting injury. Okay, so just keep that in mind. How should we dress these? Particularly these two. Because guys, if I just have that epidermis and the dermis layer exposed, not really concerned with anything, doing anything but just a dry dressing, right? I just want to stop the bleeding. But if I have significant underlying structures exposed, such as tendons, bones, maybe organs, how do I want to change up that dressing?
You make it like kind of wet or something.
Okay. Guys, normally in a normal intact skin musculoskeletal system, your bones and your tendons and your ligaments and your organs are in a what environment? A moist environment, right? So this guy, I've got bone here, I've got significant ligaments and tendons. If I have significant underlying structure exposed, then I usually am going to place a moist, sterile dressing to preserve the integrity of that underlying structure. Okay? And then I'll put a dry dressing over it. Now with this, do I have significant underlying structure? According to who you ask, right? But here I've just got tissue. So for that, how do I treat this? Dry sterile dressing. Circumferentially. Okay? But for these, to preserve the integrity of the tendons and the ligaments and the bone, I would take whatever dressing I'm going to use. Do not saturate it with the sterile water, but make it a little bit moist to preserve the integrity of the bone, tendon, ligament, and then put a dry dressing around that. Because is a moist dressing going to really do anything for bleeding control? No, because it's already like soaking up that moisture that we put the water with, right? So we're going to put a dry dressing on top of moist dressing in case there's any bleeding control we need to manage as well.
So it's just like the regular dressing, but with like saline solution or something on it?
Is it saline solution or is it kind of like just?
Typically, we try to use the sterile water. But yeah, like the big container that we keep on the truck.
Do they have like they're like.
We'll get there for chest trauma. You can use like a flush, like a saline flush. You can use that and squirt it because it's technically sterile because it's pre-contained. It's like self-contained.
So why do you prefer saline instead
We don't really, but we just prefer like sterile in some capacity.
For that top right picture, I mean, you're not gonna like attempt to like fence it back, right? Or
Yeah, no, if it's this significant, I'm not gonna try to like, re-slide it back down there. I'm just going to cover this here with moist and then probably put the entire, like this part, like the entire lower part of the arm in a dry dressing because I don't want further damage to happen to this aspect, right? So I'm going to also cover that and protect that even though it's technically intact.
Would you try to remove that?
No. They'll cut it off in the hospital. Yep. Oh yeah, they try to reattach it
Absolutely.
at all costs. It will, but it won't have the same structure. Like it'll grow back, but it'll be very thin. The collagen and all of that stuff won't be there. It won't look the same.
you can get it cracked.
All right. So amputation. Can you guys see this? It's kind of dark.
Is there one for custom?
Okay, so we can have a partial amputation and a full or complete amputation. What is this right here? Right, so that's feet, right? Here's, yes, that's the fibula. Here's leg. Is this in any capacity effectively attached?
No.
No, we've got some significant severance right here, but is it clean cut off?
No.
Is it completely separate? Is the foot here and the leg like way over here? So technically, this is gonna be a partial amputation. This is kind of both, right? This is an arm, that's a thumb, and here's where fingers should be. So this finger right here is a partial amputation because it's still connected, but the rest of this stuff is completely severed.
I'm guessing at that point, you just had to cut your losses, so to speak.
All right, guys, what do I need to do first and foremost if I have something like this?
Sure, it's not losing significantly.
Okay, so is this going to be bleeding significantly? Very highly likely, right? Because what all do we have right here, going to every aspect of your body? Arteries. All right, so guys, if we have significant bleeding, first and foremost, I need to put a what on this patient? Tourniquet. We're gonna talk about that when we come back from lunch, but I need to stop the bleeding first. And then I'll come back down here and deal with this crap. Okay, so place a tourniquet on immediately. First, after BSI, seen safe, that's the first thing you're gonna do, is put that tourniquet on if we have excessive external bleeding, okay? So how am I gonna address this part? Am I just gonna leave this open and just be like, well, here you go? No. Do I have significant underlying structures exposed? Yeah, so put a slightly moistened dressing on top of the significant underlying structure, and then as best as you can, put a dry dressing around it. Guys, if you've got something that's like totally angulated, you can attempt to put it in the position of function. But just remember, when you're moving this patient, what do we need to keep in mind? This guy in particular.
Don't touch anything with that.
So don't poke this part, but you're gonna have to make sure if you're lifting the patient's leg, you're grabbing here and you're also grabbing down there, right? Because we don't want it just gonna flop off. So just make sure when you're moving these patients, you're understanding this is like a whole package deal. You gotta grab the whole thing. Make sense?
How are we managing their response to pain? Do we have like our partners try and hold them down?
When? They're probably going to be focusing on the pain of the tourniquet, and that will be secondary. But yeah, guys, sometimes you got to tell these patients what?
This is going to hurt.
Dude, this sucks. I am so sorry. This is going to hurt, but if you don't let me do this,
Is the pain tourniquet really going to be distracting the pain of the amputation?
you'll find out when we come back from lunch.
I've had a tourniquet on my arm. It didn't hurt that much, I would think.
Maybe it wasn't applied correctly.
So it's controlled bleeding,
Control bleeding first and foremost.
wrap it up with gauze.
Then deal with the soft tissue. So for especially right here, a moist dressing, dry dressing on top of it, and just try to prevent further harm to whatever's still attached by kind of cushioning it, like just patting it, making sure we're not like letting it flop all around type thing. What if we have a complete amputation on scene? Find that body part and bring it with you. So we should have red biohazard bags, like garbage size bags. Okay, those are gonna be for severed body parts and or placentas.
Did you put like a cold pack in it?
So for severed body parts and or placentas, if you deliver a baby. Oh, was that a gag? I thought she said what?
Oh, I said,
So yeah, guys, we don't want to directly put them on a very cold surface like ice. Like let's say if we're in a house and there's a freezer nearby and be like, oh, hey, can you get some ice? And we can put that direct contact to that significantly cold environment can cause damage to like the microvessels and stuff. So if we have a cold pack in the back of an ambulance, I didn't grab one of those. I can grab one when we go to lunch. It's usually about yay big. It's a little plastic bag, and you kind of punch it, and you activate the chemicals in it. You shake it up, and it becomes cold, like in temperature. So we can maybe put a cold pack on top of the bag, the outside of the bag, but bring it with you because there's always a chance that what?
Put it back on.
They can reattach it. Okay.
Basically.
So again, guys, here's when it comes to just penetrating trauma. Here's different examples of different caliber bullets, different types of guns used for GSWs. All right, so here's an example of maybe like an entry wound that you would typically see, but we're not going to document. And there's an example of like an exit wound. Okay, different type of bullets. Point blank range, you can see kind of where the barrel of the gun was up against their skin. So again, for penetrating trauma, we don't say entry versus exit. We just say where we found it, give an approximate size, and what the condition of the skin around it looks like. Okay. Because what is likely if this is a shooting or a stabbing?
It's an assault.
It's an assault. It's probably going to go to court in some capacity. So again, you might be called as a witness. Okay, they might tear your chart apart like we watched that lawyer do in the first module. It's got to be objective. Okay, you can't put any type of assumptions or opinions in your chart because it is a legal document if any of this goes to court, and you'll be called to testify. Everybody good with blast injuries? We just talked about the 4 different kinds. Guys, I go through this very quickly because nothing changes about managing your patient's ABCs, right? If they need to be bagged and it's a trauma injury versus a hypoglycemic incident, are you going to bag them?
Yes.
If they need an adjunct, you're going to give them an adjunct if it's medical or trauma. Yeah. All right, so nothing about your APC treatment is going to change, whether it's medical or trauma. Your scene safety never changes. Okay, specifically managing these soft tissue injuries, that's what's going to change. So I don't really go through these unless you guys want me to. Is that fair? Those things don't change across the board. But again, with reassessing, with these managing the bleeding for the soft tissue injuries, you're going to go back and say, hey, I put a pressure dressing on that arm, Q5 or Q15. You're going to go look at that dressing and see if there's blood coming through that gauze. Is the bleeding still being controlled? Guys, what if I start to have blood coming through the gauze and it's like saturating the gauze? Do I need to put more gauze on there?
Yes.
Yeah. What do I do with the pre-existing dressing? But it's already wet.
I would take it off.
It's not doing anything.
You shouldn't take it off.
Leave it there, you want to put it on top.
We leave it on.
Yeah, and supply dressing on top of the
So
existing
you
one.
could jack up the cloth.
Yeah, guys, that dressing is not doing anything to effectively absorb the blood that's coming out of that injury site. But that dressing that is soaked with the blood is directly on top of that soft tissue injury. What is trying to start forming here? A clot. So it's possible that even though it's not absorbing the blood anymore, it's attached to a clot that's already formed. So if we remove that saturated dressing, it's possible we could pull off a clot or disconnect the clot that's already started to form, and we could make the bleeding worse. So if I've got my abdominal or my trauma dressing right here in my forearm, I check it 5 minutes later and they're starting to have blood seep through it, I'm just gonna grab another one, wrap it around the pre-existing one, tape it down, and maybe put a little bit more pressure on the second one, right? But you're not gonna remove any saturated dressings. We're gonna keep it on there and just put more on top of it. Everybody good with that? Okay. Guys, any type of soft tissue injury that's closed, we're gonna have that isolated swelling because why? How the body heals from the inside out, okay? The most that we can do is try to provide ice, maybe in the form of a cold pack. We don't want to put ice directly on a site, just in case it causes any micro damage. Compression and elevation. Can we do these two things? Yeah, because guys, compression and splinting is pretty much the same thing. If you put a splint on an area, you're providing structure and support and compression. And then elevation, can we elevate that body part?
Sure.
Yeah. Not much we can do for like a swollen ankle that's from a strain or a strain or a sprain. Okay, so that rises mnemonic. If your patient wants to refuse, all right, say, hey, cold on and off, wrap it up in an ACE bandage, keep it propped up, try to not walk on it as much as you can. That's just some advice we can give them if they're not wanting to go to the doctor. We always want to say what? I can't see everything that's going on the inside, so I always recommend, it's part of my job to always recommend that you go get it evaluated. Okay, now whether that's at the emergency room, at their personal care physician, maybe an urgent care facility, but we can't just straight up say, no, dude, you're fine, there's absolutely nothing wrong with it, it's not broken. What is that going to be? What if it turns out to be broken and they have like a DVT that forms and then they have a PE and they die? It's a liability thing, right? So, everybody good with signs and symptoms of shock or hypoperfusion in patients? Okay, so with these injuries, these soft tissue injuries, this blunt trauma, penetrating trauma, typically what's going to cause my patient to go into shock? Hypovolemia, hemorrhagic shock, hypovolemic shock. Okay.
In compensated shock, you have an increased blood pressure, right?
Usually, yes, for a certain amount of time, and then the blood pressure starts sinking and decompensated. What is this? This is called an evisceration. Okay, so we typically see this with GSWs or stabbings, and we particularly see them to the abdomen. All right, what am I looking at here? That's intestines. Okay, that's probably stomach, maybe some, yeah, probably stomach. Maybe a lung. Anyway, an evisceration is defined as if you have an internal organ that is now externally exposed, secondary to penetrating trauma. What do we do for this patient?
Nope.
Yeah, kind of poke it back in there? Poke the bed? No, what do we do? Okay, is this a significant underlying structure that is exposed? Yes, an organ is a significant underlying structure. So how am I going to dress that? Moist, sterile dressing to cover the entirety of that organ, and then a dry dressing on top of that. Because can I really secure like a wet dressing? Is tape really going to stick to that? No. So moist sterile dressing, and then a dry dressing on top of the moist sterile dressing.
Are we going underneath and talking about the skin of the organ as well with the moist dressing?
Yes, as best as possible. Guys, try not to like displace like what's protruding out, but I want to try as best as I can to cover all aspects of the organ with that moist dressing. GSW or stab wound. Guys, why do we usually see, most of the time we're going to see intestines in an evisceration? Why?
They're kind of narrow comparatively, and they're
Okay, so,
not a rigid shape.
okay, huh?
They're big.
They're big in what sense?
Like they take up a lot of space in the outer.
Guys, there's like 30 feet of intestinal tract in this itty bitty living space. All right, so path of least resistance is very much a thing when it comes to intestines, because if there's a small perforation or a penetration that goes to their level, they're just gonna like pew, spring out, they're spring loaded. All right, so we see this a lot. Intestines are a big source of an evisceration because they're very tightly compacted. And if we have that opening, least resistance. Because what are we typically not going to see a lot of with evisceration?
Bleeding.
External bleeding. Why? These things are corks, right? Plugging up the hole in my abdomen. I might have internal bleeding going on, but this is kind of plugging up that opening for it to come out externally. So we're usually not going to see a lot of external bleeding with eviscerations. Not to say it's not happening on the inside, but there's not a whole lot of bleeding control to manage externally. Moist sterile dressing surrounding the organ, and then dry dressing on top of the moist dressing. All right. What is that?
Is that
Stomach or intestinal tract. Okay. So cover it up in its entirety, moist sterile dressing, dry dressing on top.
They look like they're, not in the hospital. They look more.
This looks like he's being prepped for surgery. He's got a catheter placed, and that's how they place you for surgery. They keep your arms.
I thought it looked like he was on
Oh, like an autopsy table?
yeah.
I would say this is an OR. Maybe he's being bagged up here.
It does look like they're wearing gloves.
He made it to the point where they inserted a catheter, so he wasn't DOA, right? But yeah, just examples. So here's just a better visual. This is the moist sterile dressing, and then this is the dry dressing on top, and then secure the dressing either with acrylics or with tape.
Are you worried about it being like just gauze, or do you want to?
So if it's something that significant, guys, you're gonna use a big. Are you talking about like the size?
Like the
So we only do a non-permeable dressing with a sucking chestnut. So occlusive is going to mean that you're covering all sides or all aspects of the wound itself, right? But a permeable dressing is fine for this because that cotton it can breathe. We only get to the non-permeable for the sucking chestnut when we get chest injuries. Okay, so all four sides you're going to secure these dressings. Again, here's an example pencil. Here's my little Lincoln log, right? I'm going to build up a bulky dressing around the object and then secure the bulky dressing to the patient's arm or skin, however that might be. Guys, typically those Curlexes, they're great. You can just leave them rolled up just like this and then use that to secure, and then you can take another one, unwind it, and then use that to secure. We carry a good bit of them on the truck. There's usually like 10 to 12 of them on the truck, yeah.
Let's roll it up and put a hole in it and then put that over.
Just build around it. Yeah, we don't want to put anything like directly over it because there's a chance that we can, yeah, like mock it. Talk about that later. Bites. All right, make sure if it's an animal bite, you're a mandated reporter, right? For that, you are. What do you need to do? Get animal control involved. Then that's the higher authority. You pass off to animal control. They do their job. As long as you get them involved, you've done your mandated reporting. Okay. Human bites as well, not just animals. With animals worried about rabies, different things like that. But what also is inside of humans' mouths?
Lots of things.
Lots of bacteria. Okay, that might not be conducive to your body system. So again, if it's a human bite, especially if the skin is perforated, highly, highly encourage them to go to the ER, the doctor, because they need what?
Antibiotics.
Antibiotics. Definitely.
You only have like 24 hours to get the vaccine.
Something like that, yeah. All right, we're gonna do burns really quick and then we're gonna break for lunch. Burns. We already talked about this. Guys, different things go into the severity of burns, right? How hot the item or the source is, how long the source is exposed to the skin, and the area, right? We talked about the palm of your hand, the skin is thicker than like your eyelids, or we didn't tell you. type like that or stuff like that. So the density of the skin also goes into it. So guys, burns, if they're significant, if they're widespread, like if you've got, let's say 3rd-degree burns on 90% of your body, what's going to kill that person? Fluid loss first, and then infection, big one. Also hypothermia, right? What does the skin do? It regulates. If it's not there, core temperature drops too low, can't regulate it. Okay. So here we go. This is going to be, we've got 3 main types or 3 different degrees of burns. This 1st-degree burn is very superficial. Guys, a bad sunburn, that's a 1st-degree burn. Okay, the skin's not penetrated. It's got that red irritation, but the skin's still intact. Does bad sunburn hurt?
Yes.
Yeah. All right. What's still intact if it's hurting?
Nerves.
Nerve endings. Okay, keep that in mind. 2nd degree is going to be what they call a partial thickness. We've got this global. You can see he's very red all over, but we start to have the skin become compromised even more by blisters. So if you get sunburned to the point you've got blisters, that's a 2nd-degree burn. If we start to see those blisters, what color are those blisters? Yellow. What's located in those blisters? That's plasma. Okay? Keep that in mind when we talk about these guys. 3rd-degree burn. What's happening here? So we're superficial here. We're going a little bit deeper. We're going more so into the dermis. But what's happening with this 3rd-degree burn?
Burned everything.
Guys, everything is lost in these 3rd-degree burns. Okay? Down to the nerve endings, down to the hair follicles. Okay? So if you have a patient, this is kind of dark, right? There's nothing left of the skin in a 3rd-degree burn. It's a full thickness burn. How might these patients present?
Doesn't hurt anymore.
Doesn't hurt.
Hurts in the veins around.
But if you've got a substantial BSA, body surface area, you're not going to feel any pain because that nerve ending is completely destroyed. Okay? So, but if it is an isolated 3rd-degree burn, the area around it that's maybe a 2nd or a 1st-degree burn, that's going to hurt. But the actual source, the site of that 3rd-degree burn, they're not going to feel anything. Okay? Why do you think this is a cause for concern when it comes to fluid loss? Because we said that's going to be the first thing that's going to kill these patients if they have significant BSA with these 3rd-degree burns is going to be hypovolemia. Why? How?
Their pores are impacted. There's no way for that fluid to come out.
Thanks, guys. Okay, so yeah, the pores are gone, but guys, underneath the skin, we've got like that interstitial fluid, right? That plasma. Guys, if it gets to this point, it's literally because all of that stuff is gone, all of that fluid literally evaporates. We lose that fluid altogether. It's not in my system anymore. So we can go into hypovolemic shock depending on the amount of body surface area that's affected by these 3rd-degree burns. Okay. Also, too, there's no barrier here. Infection, if the hypovolemia doesn't kill them, infection's going to kill them a couple weeks later in the burn unit.
Does that fluid evaporate during the course of the fire or during the fire, after the fire?
Burn itself.
Like during the active process of the skin being burned, it just is gone. Okay. Gotta know these guys. This is like GCS. It's not fun, but you gotta memorize it. It's the rule of 9s. Okay. So this is how we're going to estimate the approximate BSA affected by these burns. Because if you call in Grady, because Grady's a what? A burn center. It's a trauma center, but it's a burn center. Grady will take a patient of any age that has burns. Okay, so you can take a pediatric patient to Grady if their only chief complaint is burns. Right, if it's like a broken bone or something like that, they won't take them. But if it's a burn, if they're two, yep, burn center, we're going to Grady. All right, they're going to want to know, hey, I have approximate number of BSA. Like, let's say I have approximately 18% of first degree burns, second degree burns, third degree burns. They want to know the degree and the approximate BSA. Okay, because the higher the number for that BSA and the higher the number for the degree, very, very concerning.
We separate it out.
So let's say I've got 18% BSA totally affected. I could say I've got 18% body surface area. Approximately half of that is third degree burns, and maybe 5% is second degree, and then X amount left. 4% first degree. Give it a breakdown if it's multiple varying degrees. Okay, so notice here the front aspect is 18, posterior aspect of the back is 18 for all ages, right? Arms for each age, 9, okay? What drastically changes? Head. The head weighs much more weight in these infants. It gets a little bit smaller in the kids, and it's only 9%. It's literally half because infants' heads are unproportionately larger than the rest of their body. Okay, genitalia is always going to be 1% across the board. The legs do vary a little bit, but the biggest change you're going to see is going to be the surface area of the head. It's got to be something you memorize. Okay. We're going to skip the funny video because I'm sure you guys want to get done with this chapter and off to lunch. But it's the episode of The Office where Michael burns his foot on the George Foreman grill. All right, guys, very important differential treatments for burns is what? Are we going to use a normal trauma dressing? No. Okay. You have a particular burn sheet or a burn pad. All right. I want you guys, I only took 3 in here. Open it up a little bit. I don't want you to take the entire thing out of the package, but I want you to feel there is a different consistency in a burn pad than a regular trauma dressing. Okay, so I want everybody to put hands on this. I want you to feel this versus a regular trauma dressing. Okay, what do you think is important or is different about the burn sheet? It is a non-stick material. I don't care if your patient has a first, second, or third degree burn. You're putting a burn sheet, a burn pad on that area affected. Why do I care about a non-stick dressing for burns?
Because if it actually sticks to that area, if you try to pull it, it's going to be very painful.
Yeah, well, it's going to be very painful, and I'm going to cause a lot more damage if I'm sticking to maybe like the plasma that's surrounding or leaking. If that sticks to a regular cotton dressing, if I pull it off, I'm pulling that plasma out. I'm pulling all of that intact skin with it. More fluid loss, more pain, more damage to the skin. Okay. Any degree of burns gets a burn pad. All right. So even if it's just on the arm, get that whole burn pad out. Maybe you can cut it to size. But again, significantly bigger surface area of the trauma dressing than the burn. So make sure if it's just the burn here, do the entire forearm.
So question, Professor A, in situations where you do have to use the burn blanket, the burn blanket, are there instances where sometimes they do get kind of cold where you'll put another blanket on top of the burn blanket situation?
As long as you've got that barrier of the non-stick, then yes, you can put a blanket on top. Because guys, again, hypothermia is a big issue. If you've got significant amount of BSA affected by third degree burns, what does the back of your truck need to feel like? an effing sauna. Because they cannot thermoregulate anymore, you're going to send them into hypothermic shock if you don't crank the heat up. So yes, you can cover them with a blanket as long as that nonstick barrier is there and that blanket doesn't come in direct contact to the affected skin. Guys, doing rotations on the burn unit during paramedic school, the one thing that I don't have any clue how people can be a burn nurse. Okay, the temperature is significantly increased, which doesn't help the smell, just like permeates the smell. Smells like chicken. Like it smells like I had a very bad burned beyond recognition patient out in the fields, and I could not eat barbecue for like a month after. Yeah, it's not like atrocious, but it's just very unsettling how similar it smells to things that we eat, right? But yeah, guys, it's extremely painful. I told my husband after that, I'm like, if I ever have like significant burns from head to toe, full plug. I would not want to live that painful life for the rest of your life, getting skin graft after skin graft and just constantly in excruciating pain. It's rough.
Do they have those like tanks?
I don't think so. I think Southern Regional has one. Oh, like the debriding things? Yeah, because yeah, they do. It's awful. It's awful. After that rotation, when I was paramedic, if I had a patient who had burns, I was very generous with pain meds. Because it's just awful. Question or Ruby? Go ahead. Thermal burns, steam burns. If you guys are cooking, you pick it up off the top off the pot. It steams. It can scald you. Okay.
It hurts like a mofo.
It does hurt like a mofo. What else do we see very commonly with scalding burns? Maybe if you eat something, but particularly what kind of patient? Kids, right? That's why we always use the back burners on our stove, especially if they get that right height when they're walking around and they can reach up and grab the pot handle. If you're cooking something, they grab it, they reach down, or they pull it down. So that's common in kids. That's another one you want to make sure that the story is adding up to the injury, because that's another common way that they will abuse their kids. Throwing hot water on them or dipping them into scalding hot like a bathtub. So make sure your story matches your entry pattern with that one. Inhalation burns. So yeah, airway. Guys, structure fires. This is a big thing that can happen. We've got external burns, but inhalation also. So you can see the soot and just the degradation of the skin that's lining the airway. If your patient's face looks like this, we've got the scalding, we've got the soot burns, be very concerned about their airway. What can you do for this patient? Humidified oxygen. Hopefully ALS is close by. Okay, but yeah, humidified oxygen for inhalation burns. Again, if they've got any type of like smoke or soot on their face, I would just go ahead and even if you can't see like the actual scalding, just give them humidified oxygen anyway. Okay. So this is trachea, esophagus, inhalation injuries from a house fire. Chemical burns, we treat them the exact same way, right? Burn sheet, calculate BSA, rule of nines.
Are you gonna like rinse them?
If there's still residue on the skin itself, yes, but if not, no. Electrical burns, guys, be aware that typically if you have like an electrical burn from an electrical source, there's usually an exit injury. All right, so that energy is coursing through the body. Again, energy is not created or destroyed, only transferred. Has to have an exit route. All right, so sometimes we'll see these open injuries where the source of electricity exits the body. Treat it just the same, burn sheet, calculate BSA. Taser injuries, it is within your scope at Grady to remove taser barbs. You would follow the chain of custody if the patient's in police custody or if they need to be transferred to the hospital. That's something you'll learn specifically when you work for Grady. But they hook into you, just grab them at the base and pull out. What's something else we need to worry about for electrical burns too?
The thing that shot are still powered.
Okay, so scene safety, absolutely, but also for our patient status. Heart, right? If I have a surge of electricity for a heart that doesn't need an AED, can I cause problems?
Yeah.
Yeah, we definitely have cardiac dysrhythmias with electrical burns.
So for like BLS, we can't really do anything about that. Just watch for cardiac arrest.
Talked about those, talked about this. We good? Okay, questions, comments, concerns?